Can you diagnose this case? Start with clue 1, Raynaud phenomenon. Now look at the hands. Puffy fingers, sclerodactyly and digital pitting scars. But the key clue is skin distribution. On this slide, the thickening is not limited to the fingers. It extends proximal beyond the wrists and forearms, with possible involvement beyond the elbows or trunk. That helps us classify the disease. Now add reflux or dysphagia, suggesting esophageal involvement, and exertional dyspnea, suggesting possible lung disease. So pause here. What diagnosis explains vasculopathy? Skin thickening, reflux, and breathlessness? And once you make the diagnosis, is it limited or diffuse? Which organ complications must not be missed? Now, let's reveal the answer. This is diffuse cutaneous systemic sclerosis. Why diffuse? Because the skin thickening extends proximal beyond the wrists toward the forearms and may involve more proximal skin. Limited disease usually affects skin distal to the elbows and knees, plus the face. Diffuse disease involves more proximal skin, often progresses faster, and carries higher risk of organ involvement. Now look at the high-yield clues. Raynaud reflects vasculopathy. Sclerodactyly and tight shiny skin reflect fibrosis. Reflux and dysphagia suggest esophageal dysmotility. Dyspnea should immediately make us think about lung involvement. The core pathophysiology is vasculopathy, immune dysregulation, and fibrosis. Now compare limited versus diffuse. Limited systemic sclerosis is often linked with CREST, features, and anticentromere antibodies. The major long-term concern is pulmonary arterial hypertension. Diffuse systemic sclerosis is linked with anti-SCL70 and anti-RNA polymerase. The major complications are interstitial lung disease and scleroderma renal crisis. So the key classification clue in this case is proximal skin thickening. Now the most important teaching point. Do not stop at the diagnosis. Actively screen for the big 3 complications. First, interstitial lung disease. Think dyspnea, dry cough, reduced exercise tolerance, or low DLCO. That is why PFTs and HRCT chest matter. Second, pulmonary arterial hypertension. Think exertional breathlessness, fatigue, syncope, or reduced exercise tolerance. Screen with echocardiography. Third, scleroderma renal crisis. This is an emergency. Think rapid skin thickening, new severe hypertension, rising creatinine, or microangiopathic hemolytic anemia. At baseline, check ANA, anticentromere, anti-SCL70, and anti-RNA polymerase through. Assess lungs with PFTs including DLCO and HRCT chest. Screen pulmonary pressures with echocardiography. Monitor kidneys with blood pressure, creatinine, and urinalysis. Final message. Systemic sclerosis is not just a skin disease. It is a multi-system disease. Advanced question. Which antibody would make you especially concerned about diffuse disease with scleroderma?